Okay. All right. So thank you, everyone. We will be starting this webinar now. Welcome and thank you for joining us in this webinar today. My name is Oluwakemi Akagu, and I work as an online platforms manager with Breakthrough Action at Johns Hopkins Center for Communication Programs. I will be moderating today's webinar. We will start off with housekeeping and introductions while we wait for others to join us. Next slide, please. This webinar will last an hour and a half, and we will be providing live interpretation in French. If you would like to listen to this webinar in French, please click on the interpretation icon at the bottom of your Zoom screen. Click on the language, your preferred language, which is French, if you want to listen in French. And if you are listening to this webinar through your phone or Android device, next slide, please. Please go to the meeting controls and press the 3 dots, then press the language interpretation. Then you can select English or French to be able to listen to the webinar in French. Thank you. Next slide. For housekeeping, please introduce yourself in the chat box. We are very happy to have you join us today and would like to know who you are and where you are joining us from. If you need help with the technology, please send a private chat to Kendra Davis for help. If you have questions for the presenters, add them to the chat. Questions will be answered during the Q&A session. And lastly, this webinar will be recorded in English and French and shared with everyone registered. Next slide. Okay, so for those of us who may not be familiar with Breakthrough Action, Breakthrough Action is United States Agency for International Development's flagship global social and behavior change program, and is a partnership led by Johns Hopkins Center for Communication Programs in collaboration with partners Save the Children, Ideas 42, Think Place, Canva Collective, VIAMO, and the International Center for Research on Women. Recently, Breakthrough Action developed a suite of practical programmatic tools to help users identify factors influencing the behavior of facility-based providers and to support positive provider behavior. In this webinar, speakers will be sharing this new exciting suite of tools and share examples of how these tools have been applied in different countries to date. This webinar will feature opening remarks, 4 presentations, a Q&A session, and an announcement on an upcoming provider behavior change workshop, which will help participants learn how to apply these tools we are presenting today in their work. So we will be going straight on to the day's agenda. Next slide. We will start with our opening remarks, which will be given by Foyeke Oyedokun Adebagbo. Foyeke is a program management specialist with the Health Office of US, let me start again. Foyeke Oyedokun Adebagbo is a program management specialist, social and behavior change with the Health Office of USAID, Nigeria, where she supports the systematic application of behavioral evidence and insights into health sector strategies and program designs. Over to you, Foyeke, for your opening remarks. Thank you.
Thank you so much, Kemi, and I hope you can all hear me okay. Thanks for the introduction. So distinguished colleagues, good morning, good afternoon, and good evening to you from wherever you're joining us from. Thank you so much for taking the time to join us today. It is my pleasure to welcome you to this important and really timely webinar that's titled, What Are We Missing? Expanding Understanding of Factors Influencing Healthcare Provider Behavior. I'm sure we all agree that healthcare providers, whether they're facility or community-based, they do play such a critical role in any health system, especially given their close, frequent interactions on a day-to-day basis with clients. The quality of these interactions has implications for how clients experience care, how they perceive quality of care, whether they trust in or continue to use health services. It also does have implications, and have can affect the likelihood that they would adopt or maintain healthy behaviors, and overall that we will achieve the desired health outcomes. So as donors and practitioners, we've come to acknowledge this very critical role that providers play and how they affect individual and population health outcomes. And with this acknowledgement has also come this growing consciousness that healthcare providers are people themselves, they're actors, and that they're operating within such a complex health ecosystem where they have to interact with several factors, and that these factors then interact with each other and have an impact on the providers as well. So the way a provider will act or behave while providing care is typically an outcome of a complex set of factors, some of which could be internal, to others that could be external as well. So at USAID, our SBC investment adopts systems thinking lens when designing and implementing programs that aim to shape provider behavior. We have a vision for health system strengthening that underscores social behavior change as an approach to empowering clients and providers, but also as a key component of equity-focused programming. As practitioners, as donors, we've now all come to acknowledge that effective provider behavior change programs must evolve beyond interventions that address knowledge, skills, and capacity gaps. But while those are very essential, because we do know now that they're not typically sufficient to result in the kinds of provider change, behavior change that we're seeking to achieve. So what are we missing? Are we missing elements of program design that hinge on a better understanding of social and systemic factors? Are we missing designs that recognize that service providers are humans and that they need resources and support and the right dose of motivation? Or are we missing the consideration that context always matters? So programs need to think about what works or what does not work in resource poor settings, especially where providers really have to do so much with so little, or in a system that's already overburdened by shocks or pandemics such as COVID-19. Fortunately, this is why we're here today, to get answers to these questions of what we're missing. During this webinar, we have an amazing lineup of experienced speakers who would reiterate the importance of more fully understanding provider behaviors, what we're missing, where the missing links and gaps are. And they would also share, like Kemi had said earlier, this exciting new set of tools that we could use to better understand provider behavior. Examples of how these tools have been applied in different countries and contexts, because like I said earlier, context always matters. It is my hope that we will come away with a renewed understanding of how to apply these tools to our own work, designs, and constructive deliberations. I wish us all a very successful webinar. Over to you now, Kim.
Thank you very much for your care. So we'll move on to the presentations. Our first presentation will be on the provider behavior ecosystem map and will be given by Danette Wilkins. Danette Wilkins is a family planning program officer with Breakthrough Action at Johns Hopkins Center for Communication Programs. She supports global coordination and initiatives under the Population and Reproductive Health team. Over to you, Danette.
Thank you so much, Kemi. Greetings to everyone. I'm very pleased to be with you all today and to share the Provider Behavior Ecosystem Map, a tool for thinking systematically about provider behavior. Next slide. Next slide. In today's presentation, I will focus on how applying a systems lens to understand provider behavior can help us as practitioners, researchers, advocates, and donors working in social and behavior change and service delivery to develop more effective, supportive provider behavior change programs and initiatives. Next, please. Provider behavior is defined as what healthcare providers do and do not do in their professional capacity. It includes the range of behaviors that happen before, during, and after an interaction with a client in the health facility or other service delivery setting. It is important to consider the behaviors that happen before or after an interaction as well, because they can also have bearing on the relationship dynamics experienced between healthcare providers and clients, the quality of care delivered, and the client health behaviors and outcomes achieved. Next slide, please. In considering provider behavior, we must remember that providers are people too. Healthcare providers need appropriate support and sufficient resources to deliver high quality care and improve client health behaviors and outcomes. Like all people, providers exist and operate within a large, complex system that directly and indirectly impacts who they are and how they act. The system particular to healthcare providers is called the provider behavior ecosystem. Next, please. The provider behavior ecosystem places the healthcare provider at the center. Surrounding the provider are the multi-level factors that can shape and influence their behavior. This system's lens allows us to view and evaluate these factors and contemplate why approaches and strategies that go beyond provider training, refresher courses, and supportive supervision are needed to shift provider behavior in a particular environment. Next slide, please. As a thinking tool, the provider behavior ecosystem allows us to examine the wide-ranging factors that can shape and influence facility-based provider behavior, observe the interactions and connections between these factors, consider different approaches and strategies needed to address these factors across the ecosystem, and ultimately design and implement more supportive, effective provider behavior change programs and initiatives. Next, please. The provider behavior ecosystem map is an interactive map that visually displays the complex system in which providers operate. It is organized around the provider at the center and includes key actors and entities, influence factors, component groupings, and components. In the center of the map, you'll notice the actors, or individuals and groups, and entities, or organizations and institutions, that interact with providers across the system. You'll notice that the actors and entities are placed in their relevant level of the socio-ecological model: individual, interpersonal, community, organizational, or public policy. For those with less familiarity, the socio-ecological model contemplates the complex interplay between individual, relationship, community, and societal factors. These actors and entities are color-coded to align with the influence factor with which they are primarily associated. Additionally, the map is organized according to influence factors, the overarching groupings of actors, entities, and other elements that interact with one another and influence provider behavior. Each influence factor then divides into component groupings, which further divides into components. Component groupings and components are the more specific elements that can affect provider behavior in any given environment. These influence factors and components interact and connect with one another, and these interactions and connections are called interrelationships. The degree to which influence factors and components shape and influence provider behavior depends on context and requires additional information gathering and further analysis. Next slide, please. We won't be doing a demonstration for you today, a live demonstration that is, but I would like to further break down some of these components for your understanding as you explore and navigate the provider behavior ecosystem on your map afterwards. As you click on the key actors and entities in the center of the map, a pop-up window will appear with a description of the actor or entity and how it can impact provider behavior. In the example here, we have religious institutions. Examples of other key actors and entities include the following: family members, colleagues, clients, community leaders, community-based organizations, facility leadership and management, health system, accreditation and training organizations, and more. Next slide, please. As you click on the influence factors along the innermost ring with multicolored blocks, a pop-up window will appear with the description of the influence factor and how it impacts provider behavior. In the example here, we have workplace environment. Examples of other influence factors include the following: the individual, personal relationships, the client, community context and social norms, health system governance, and country and geopolitical contexts. And as mentioned before, these influence factors are arranged according to the relevant level of the socio-ecological model. Next slide, please. As you click on the components along the outermost ring with small circles, a pop-up window will appear with a description of the component and how it can impact provider behavior. In the example here, we have a snapshot of the influence factor, which is health system governance, its component groupings, which are quality assurance, process and practice, and leadership, and the individual components that fall under each component grouping. This snapshot allows you to appreciate how these three elements relate to one another in the map. Next slide, please. And here's an example of that pop-up window that I mentioned that will appear with the description of the component and how it can impact provider behavior. In this example, we have the component expectations for care, which falls under the influence factor at the client level. Next slide, please. Another important feature of the provider behavior ecosystem map are the interrelationships across the ecosystem. As previously mentioned, these interrelationships are the interactions and connections between components and influence factors. In the example here, we have selected the component labeled identity, which falls under the provider. In doing so, the interrelationships with other components and their respective influence factors are revealed to us. Here we see that the identity component relates to and interacts with diverse components across the entire ecosystem. This prompts us to further examine and appreciate how what happens in one part of the ecosystem can have ripple effects across the entire ecosystem. It is these interrelationships that help facilitate more holistic thinking about provider behavior, as well as approaches and strategies for addressing these factors that influence provider behavior at the different levels. Next slide, please. This thinking tool can be used across diverse country contexts, various stages of program or project implementation, and different service delivery settings to deepen understanding of provider behavior. For example, it can be used to inform formative research priorities and highlight gaps in provider behavior data. It can be used in project design and implementation to explore and prioritize behavioral drivers to address through provider behavior change efforts. It can also prompt dialogue around what behavioral factors to include in monitoring and evaluation plans. Or it can be used to advocate for broader support and additional resources for healthcare providers and provider behavior change initiatives with governments and donors. After this presentation, you will learn more about how the provider behavior change ecosystem map was applied to provider behavior change efforts by the West Africa Breakthrough Action Team, which works with partners and stakeholders to improve family planning provider behaviors in Niger, Togo, Burkina Faso, and Côte d'Ivoire. Next slide, please. In addition to the provider behavior ecosystem map, we have developed related products to facilitate your use and understanding of this thinking tool in support of provider behavior change efforts. There's a high-level brief, a detailed guide, a prioritization worksheet for considering individual components, and a deck of printable cards with the individual components that can be used for in a workshop setting, for example. I will share links to the different ecosystem products in the chat after this presentation. As mentioned earlier, the degree to which influence factors and components shape and influence provider behavior depends on context and requires further information gathering and analysis. It is very important to conduct assessments and/or review secondary research to identify which of these wide-ranging factors are most relevant and influential for the target groups of healthcare providers in the environment in which you're working. Later in this webinar, you will learn about other tools that can be paired with the provider behavior change ecosystem, the provider behavior ecosystem map to develop more effective supported provider behavior change programs and initiatives. Next slide, please. Thank you very much for your time today, and I look forward to reviewing any questions and comments in the chat. And once more, I'll be dropping links to all of those associated ecosystem products in the chat for your further review. Over to you, Kemi.
Thank you, Danette. And we move on to the next presentation, which will highlight practical applications of the provider behavior ecosystem map. And this presentation will be given by Alice Molina. Alice Molina is engagement manager with Canva Collective, one of the partners of Breakthrough Action. On Breakthrough Action, she supports country teams in development and implementation of their family planning interventions. Over to you, Alice.
Great. Thank you, Kemi, for this introduction. I'm delighted to join this webinar, and it's really nice to see so many people in the chat. So I am going to speak about a very practical application of the provider behavior ecosystem. And I'm going to take the example of WABA, so the Breakthrough Action Program that is implemented in Niger, in Burkina Faso, in Côte d'Ivoire, and in Togo. Next slide, please. Great. So for the one who are not familiar with the WABA project, one of the key objectives of the project is to improve access and the quality of services by working with provider and by addressing some of the challenges that provider may face when they are counseling women and young women around their sexual and reproductive health. And so to ensure that we were designing interventions that are actually tailored and context specific, we use the Pbc flowchart, which I'm sure a lot of you are familiar with, but basically follow this kind of three-step process. Phase one was very much about understanding some of the challenges that providers are facing. Phase two is about designing, testing, prototyping solution to address some of these challenges. And then phase three is around applying this solution at a larger scale. And just wanted to highlight that here, WABA Breakthrough Action is very much playing the role of technical advisor to the government, really helping them design new solutions that can then be scaled up. In the first phase of the project, Camber Collective basically did a survey among providers. I'll talk a bit about the methodology, but we tried to really understand what were the key challenges that providers faced in each of the countries where we were operating. And the goal of that research was basically to identify one top priority challenge in each of the countries to be able to develop specific solutions that really responded to both the country needs and also the government priorities. Next slide, please. Perfect. So we conducted a number of semi-structured interviews, about 40 in each of the countries, with Ministry of Health representatives, with implementing partners, and with providers themselves, including supervisor of providers. And we will also reach out to experts in the Pbc space, and also learned a lot from some of the work that had already been done on the community dialogue, for instance. And so we spoke to these people about, what are the key challenges that providers are facing, what training and supervision do they have access to, what tools are they using, what might be missing, to really use that research to be able to engage in a conversation with partners and with government representatives to identify in each of the country specific challenges and therefore specific solutions. Next slide, please. So we actually use the provider behavior ecosystem a little bit late in the process. We started collecting all of that information, and as you can imagine, kind of, had like long Word document, long Excel with like all of that kind of complex information. And very quickly, we actually, discover like the provider behavior ecosystem that was being developed. And we basically used it to structure and present that information to the partner and to the Ministry of Health. So it's interesting to, in this process, we didn't use it at the very beginning, even though I'm sure it would have been really useful. We really use the ecosystem as we were going through the process of collecting this information in order to present the information to partners and to have a conversation. And so what you are seeing on this slide is actually what we presented back to the Ministry of Health and to the partners in the 4 countries. So we had the 4 countries all together joining a meeting, and we started presenting that information. So I'll go quickly through the content, but I actually want to speak more about the process. But just to give you an understanding, we had obviously challenges that were related to the individual, so the provider himself, in terms of knowledge, in terms of skills, in terms of their attitudes, or even their kind of own personal kind of bias and motivation. Concern also were surfaced when it came to like the relationship of provider and their interaction with their family and community, with very much a tension between their professional life and then their personal life. And then also a number of issues related to client experience, which we were anticipating in terms of like the counseling in itself, the judgment maybe that provider had, or kind of limited explanation on specific methods. Next slide, please. So on the left-hand side, you have that would give you an overview of some of the challenges that were described by providers on the kind of country and geopolitical landscape, question around the funding for provider behavior change, the lack of coordination came up among the health partner, issues related to health system governance, so lack of tools, of equipment, cost of services in general, aspect related to like the supervision and training, and then issues related to workplace and the workplace environment that were, voiced by providers around like maybe poor HR management, disorganization within services, waiting time, and then finally aspect that spoke to like the community context and the social norms. Next slide. So we presented this, as I said, this very kind of complex ecosystem and work with each country to actually kind of contextualize a little bit more these challenges and work with them to decide, what was like the one top priority that Ministry of Health and partner wanted us to support with and wanted WABA to really help them on. And so as the outcome, one of the outcomes of this series of workshops was that Burkina Faso decided very much to work on provider empathy. In Togo, there was a real choice to actually address questions around organization of services and waiting times. And then finally, in Côte d'Ivoire and in Niger, what appeared to be, one of the biggest bottlenecks was around kind of the lack of counseling tools or the complexity of the existing counseling tool. And so that was the basis to identify a challenge. And we have then been working with, all of the WABA partners to develop solutions and prototype and test this solution to address each of these challenges. Next slide. So I just wanted to finish my presentation, really thinking about like what was helpful with this ecosystem, maybe to help some of you as you are thinking about using it. So The ecosystem was extremely helpful in 4 ways. I've mentioned number 1, it's around like organizing and visualizing the information that we had, and really using that as a way to engage providers and to engage Ministry of Health representative on this issue. The second aspect, I think it's really important, is it actually forced us to have a very systematic and comprehensive view of the provider ecosystem. And you know, sometimes you forget, like you don't have that systematic way of thinking, and it really forces us to look at every single component that could influence the provider. Thirdly, and for me that was the most interesting, it actually helped us to have an objective conversation with the participants. Because when it comes to provider and in particular people behavior, and you speak to a lot of stakeholders, you will quickly realize that everyone has, you know, their own version of the story. So the providers are going to say, you know, it's the health system fault. The government is going to say, oh no, it's the provider, and then the community is going to say, oh, it's like the entire system. And so in some way, having that ecosystem really helped everyone to acknowledge that we were dealing with a complex issue, that it was not, you know, one person or one party behavior fault, and really help us have an objective conversation where we actually came together to say, okay, how do we organize this and how do we address that as a community? And then lastly, it helped us prioritize and focus. And as I say, we really had this effort of focusing on one aspect and one challenge. So one thing to consider though is, you know, the beauty of the ecosystem is that it's a model, and it's great because it helps you simplify like real life, right? But it's also a big challenge because it actually helps you simplify real life. And so what I would just kind of call out or watch for is, while the ecosystem is extremely helpful, it's important just to really keep in mind how the different pieces of information really link to one another. And then lastly, on the possible application, I think that was covered by Danette, but really thinking about how the ecosystem can be used at each stage of the program, research, design, and monitoring and evaluation. Next slide, please. Great, so this is the end of my presentation. We'll be very happy to answer questions later, and thanks so much for listening in. Over to you, Kemi.
Thank you very much, Alice, for your presentation. So before we move on to the next set of presentations, we'll take a moment for everyone to share their reflections on the provider behavior ecosystem map by answering these 2 questions. Next slide, please. Okay, so the questions are, how do you see yourself, how do you see yourself applying the ecosystem to your work? And what would you need to apply the ecosystem to your work? Please share your reflections on these 2 questions in the chat box. Okay, so thank you to everyone who has shared their reflections in the chat box. Please keep on sharing your reflections as we move on to the next set of presentations. Next slide. So our next set of presentations will focus on the Provider Behavior Change Toolkit. And the first presentation will be given by Heather Hancock. Heather Hancock is a Senior Program Officer with Breakthrough Action at Johns Hopkins Center for Communication Programs. She supports SBC for service delivery and provider behavior change initiatives with the Population and Reproductive Health team. Over to you, Heather. Thank you.
Thank you, Kemi. Good morning, good afternoon, good evening to all of you. I'm really excited to be here with you today to share a set of tools that builds on the provider behavior ecosystem that we just heard about. And these are the Provider Behavior Change Toolkit. Next slide, please. So there are a great number of really wonderful provider behavior change tools that already exist. And this toolkit really seeks to build on those tools. However, when we were going through the process of designing the provider behavior ecosystem, we found that stakeholders kept bringing up repeatedly some of the gaps that tools that currently existed did not quite meet. And so we did a further review of existing provider behavior change resources. And we also have gone through a human-centered design process that revealed some gaps and opportunities that an additional set of tools could address. And some of those things that we found were that we need a set of tools that really help us to empathize with providers and offer more supportive solutions. So not seeing them as the problem, but really seeing them as part of that process, and focusing more on the supportive solutions. We also needed a set of tools that helped us to increase our understanding of and address root causes of behavior. And then, as we've already heard today, we need to look at provider behavior from more of a systems lens and not just think about the individual provider and what they may be doing, but also looking at all those other factors that are influencing providers as people. And then we also heard that we really need a set of tools that provides guidance on how to prioritize all of those factors to address. As you just heard from Alice and Danette, there are so many different factors that could be influencing a provider's behavior, and it's hard to figure out where do we even start with all of these. And so there was a need for tools that helped prioritize those factors. There was also a need to continue encouraging local solutions to provider behavior change challenges. We also needed a set of tools that would enable users to expand the range of potential approaches and strategies that they use. We saw a continued reliance on training and supervision, which are certainly important, but cannot be the only solutions that are applied in order to address these complex issues. And finally, we saw that there was a need to facilitate greater coordination between different actors who are focusing on provider issues, not just between social and behavior change programs and service delivery programs, but also different actors who are focusing on addressing provider challenges, including the ministry, coordination committees, and health committees at the facility level, and then different implementing partners. And we also heard that people wanted tools that would more directly measure provider beliefs, attitudes, and norms. Next slide, please. So this set of tools was really developed to respond to those needs. And broadly speaking, the Provider Behavior Change Toolkit is designed to support the design, implementation, and evaluation of effective facility-based provider behavior change initiatives within reproductive health programs. There's also a set of tools that are very similar that address initiatives within malaria programs. And more specifically, they aim to help users identify, understand, and prioritize factors that are influencing provider behavior, and then allowing those users to design and implement locally appropriate, supportive provider-related initiatives that really do address those root causes of provider behavior. Next slide. So to produce this set of tools, the Breakthrough Action Project facilitated a human-centered design, co-design process which included stakeholders from all around the world. This included service delivery and social and behavior change stakeholders from family planning and reproductive health, as well as malaria. And this group came together to help establish the goals and objectives and audiences that we might want to reach with these sorts of tools. And then we worked together jointly to design prototypes. Breakthrough Action also went through a process of reviewing the existing provider behavior change tools and resources that are out there. And we conducted a literature review on provider behavior change theories, strategies, and approaches. And then finally, we conducted 3 rounds of testing in several countries, including Uganda, Guyana, South Sudan, and Kenya. And they're just being finalized after this last round of testing. So they're not quite ready to be shared today, but they will be shared and available very soon. Next slide. So before I dive into the tools themselves, I wanted to provide just a quick overview of the toolkit. The toolkit employs a multi-level approach. As we heard from previous presentations, it's really to understand what's influencing provider behavior and to generate those local and relevant solutions that we hope to see. We need to look at behavior, provider behavior, from multiple lenses. And this toolkit seeks to get those perspectives and input from a variety of stakeholders throughout this process. And so we seek to get in that input and those perspectives from clients, from providers, from community members, district health management or county or state health management teams, and the national ministry staff. And in this way, it really allows us to triangulate the data and get a more holistic picture of what's really happening, what's truly influencing provider behavior. The toolkit also uses a systems lens, and in that way it builds on the provider behavior ecosystem to explore the range of potential factors that could be influencing provider behavior and then prioritize those factors. It's designed to be implemented by a multidisciplinary core team. In that way, it can facilitate mobilization of different actors, real dialogue, and greater sustainability overall. And there's also an option to include a peer provider from other facilities to encourage more of that open and supportive discussion and making sure that we're not framing this punitively or as providers as the problem. And just to note that the toolkit is designed primarily for facility-based providers, but adaptations are both possible and planned for community health workers at different levels. And overall, this toolkit is meant to be a holistic approach to provider behavior change that takes users from the diagnostic process through to synthesis and then all the way to programmatic design and implementation. And I'll talk a little bit more about each of these components in detail. Next slide, please. So the first component in the toolkit is a set of diagnostic tools. And these tools are really designed to help users understand what is influencing provider behavior from multiple perspectives, as I mentioned previously. And the outcome of this diagnostic process is the identification of pain points, challenges, and opportunities. Next slide. To understand what is influencing provider behavior, this toolkit has 4 diagnostic tools or activities. The first one is a journey map tool for providers. And this journey map tool really allows providers to reflect on their experience as providers, think about the factors that are motivating their daily work, and the factors that might be preventing them from accomplishing their best work. And it uses influences from the provider behavior ecosystem to be able to capture that full system of what might be influencing providers. The next tool is a set of diagnostic scenario cards for clients. And the core team uses these scenario cards. They present images and scenarios alongside those images, and they ask clients a set of questions to gain a better understanding of the experiences that those clients have receiving family planning related services. So this thinks through what are the processes, what are the motivators, what are barriers, to really get a sense of how that process looks for clients. And then to understand what influences provider behavior from the district or county or state level, we have a service blueprint. Some people may be familiar with this kind of tool. It really allows those state or county or district health officers and the Ministry of Health to develop a complete overview of those ongoing actions performed, the processes related to them, and then consequently to be able to identify opportunities for improvements in how they support providers and thinking through that level of what's influencing provider behavior. And then finally, the toolkit has a guided facility or shadowing tool. And this allows the diagnostic team to observe conditions in the facility, think about and look at the interactions between clients, between providers themselves as colleagues, and also the clients and providers, and the providers and their supervisors. And it also allows the team to look at what activities are happening in the facility, whether that's group talks or what's happening more informally. This allows the team to really see what can't be articulated by people throughout this process, or what may not want to be shared. People may not feel comfortable sharing those things. So this helps triangulate that additional piece. And the team then can explore already known areas of provider behavioral challenges or identify new potential behavioral challenges. Next slide, please. The next component in the toolkit is a set of synthesis tools. And these tools are designed to help users synthesize all the information that is gathered during that diagnostic phase. And through these tools, the team is able to identify common themes or trends related to challenges and prioritize which factors they should address, and then also identify opportunities that might present themselves. Next slide. The synthesis tools include several processes for reviewing all of the information gathered, synthesizing it, and then prioritizing the data. The team goes through a process of reviewing all of the outputs from the diagnostic process and then synthesizes those using either a synthesis tree or a circle or a table that's part of the package. And then they start to prioritize those factors that they've discussed based on discussion and an optional use of a prioritization matrix, which you can see here. And then finally, they fill out a point of view template to capture any surprises that are coming up during that process, the causes that they might be thinking of, and then opportunities for each of those challenges that have been addressed. Next slide. And then the last component in the provider behavior change toolkit is the programmatic tools. And these tools are designed to enable ideation around solutions for those prioritized challenges that came out of the synthesis process, and then also to spark collective action. The process allows users to come up with a solution set, identify what resources are needed and available, and identify roles and responsibilities for the tasks, and then finally to create coordination systems to ensure action. Next slide. The programmatic tools start with an ideation process that involves multiple stakeholders coming together to brainstorm solutions to the prioritized challenges. So these include some of those that I already discussed earlier, including clients and community members, supervisors, providers themselves, ministry staff, to really get a wider picture of what can happen. And the tool utilizes a set of inspiration cards to showcase potential provider behavior change approaches and strategies as building blocks to potential solutions. So these should not be the only things that are included, but they're starting pieces for people to get thinking about what they could do. And then they use a process of yes and, or building on, or combining some of those to think about what's locally appropriate. And then once those solutions have been identified, the team uses an action planning tool to identify how they will implement solutions. Next slide, please. So just as a quick teaser to what Kemi will share later, we do have an opportunity to apply these tools in different settings through regional workshops that will be held in May or June of this year. They will be team-based, and there will be an opportunity to create an action plan for implementation. And Kemi will share more details about how you can apply for those workshops and what those workshops will entail as we move forward. But I wanted to let everyone know that there will be an opportunity to learn how to apply this suite of tools. So over to you, Kemi.
Thank you, Heather, for your presentation. And we'll be moving on to the last presentation, which will be given by Kenny Athanasios. Next slide, please. Okay. Okay, and the focus will be on lessons from testing and adapting the Pbc tool in South Sudan. Kenny is the SBC advisor with Breakthrough Action South Sudan at Johns Hopkins Center for Communications Program. Over to you, Kenny.
Thank you very much, Kemi. Good morning, good afternoon, everyone. Yeah, happy to be here to share with you our testing of the provider behavior change tool in South Sudan. As most of you are aware, South Sudan is is one of the newest countries in the world, which got its independence from Sudan in 2011, after 2 decades of civil war with Sudan. And due to this war, much has been destroyed. The healthcare system remains poor. The shortage of qualified health care workers, and also shortage of functioning healthcare facilities. Consequently, South Sudan has one of the world's most health indicators. For example, in regards to reproductive health, it has about 789 deaths per 10,000 live births of infants. The contraceptive prevalence is just at 4.7%, and then there is also 1.7% of women who report using modern contraceptives in the country. Breakthrough Action South Sudan's activities aims at improving the uptake of healthcare services in the country. Next slide, please. Okay, the initial process of the provider behavior change tool, what we did in the country was that we introduced the provider behavior change to the Ministry of Health, where we were able to brief them on the importance of the tool. For example, we let them know that the provider behavior change tool aims at helping and identifying prioritize related provider behavior and facilitators to improve service delivery to the populations, and also offer guidance and programmatic support to decision making, which I think was the issue. The Ministry of Health gave us a green light to go ahead with the testing of this provider behavior change tool in the country. Next slide. Okay. In the initial processes of the provider behavior change tool testing in the country, we selected at least 2 locations where we, as Breakthrough Action, intended to conduct this provider behavior change tool testing. But because we are working in collaboration with other partners, and one of our key partner in the country, that is the Momentum Integrated Health Resilience, suggested we also test this tool in Yambio, and we then decided now to conduct the testing in 3 locations, that is Juba, Wau, and Yambio. What happened is that we also selected at least 5 facilities where we shall be testing this, and 3 of the facilities were supposed to be in Juba, 1 is supposed to be in Yambio, and then 1 to be in Wau. From these locations, from these facilities that we intended to test in, we had Bazia Jadid, we had also Yambio State Hospital, we had Best Medical Clinic, that is in Juba, we have Juba Teaching Hospital, and there's one which is at a remote location called the Aru Junction Primary Healthcare Unit. So from the testing that we conducted, we managed to test in 3 facilities. One of it is Yambio State Hospital, Bazia Jadid PHCC, and then we have the Best Medical Clinic, that is a private clinic in Juba. Purposely because in Yambio is a semi-urban location, Bazia is a remote location, and then Best Medical Clinic is a private clinic, and it happens to be within the city of Juba. So the plan was to test this provider behavior change tool in at least 3 settings. One is at a city or an urban location setup. The other one should be in a semi-urban location setup, and the other one is a remote location setup. So all these 3 that we've tested in, I think has matches all these the criteria that we intended to use. Next, please. Yes, in the provider behavior change tool testing activities, we had interviews, and these interviews we had them with the healthcare workers, we had them with the government officials from the county and the health and the state ministry of health department. We also had interviews with the implementing partners in the country, and also we interviewed clients, and these are the family planning users. We also interviewed facility in charges, and also conducted ideation session after the testing of this provider behavior change tools in these 3 locations. Next, please. Okay, some of the key findings from testing the provider behavior change tools in these 3 locations include one of it is being social norm influences provider behavior change, especially gender-based violence, and that by that I mean men usually make decisions for their wives to go and take family planning of their choice, and usually what happens is when a woman goes into the health facility to go and access any of these methods that are available, and when they didn't get that specific methodology which are instructed by their husbands, they tend to refuse to take that, and then it sometimes throws them into let me say a quarrel between them and the provider, and this is sometimes as a result of the lack of these commodities in the facilities. One of the other findings we also realized was that health providers felt comfortable providing family planning services to unmarried and the independent clients, and that is because of the repercussions the health providers usually get from the husbands of the women who tend to use family planning services secretly. We also found out that some communities have confidence in some of the facilities or providers. For example, in one of the locations where we tested this, we got that clients flock to one facility more than the others, giving pressure to the limited number of the health providers in the facility. Yeah, okay. There's also bias of misinformation that impacts the interaction between the health providers and the clients. Usually, clients come with those misinformations, and those are the issues which sometimes makes it difficult for them to be able to interact very well with the providers, because they have this kind of thinking in their minds, like this family planning does this and this does this to the bodies, and they tend to now think of having that family planning of their choice, not from the let me say the information provided to them by the providers, but from the information they got out from their peers in the communities. Next slide. The other findings we also found out was that that is in relation to counseling barriers. Okay, due to availability also, usually providers tend to advise clients on the available methods, but again, because providers come with their own methods, or the method they thought or they've heard from their peers in the community, sometimes they decide not to listen to this and then be able to, okay, they decide to go home without any methodology, any family planning methods from the ones shared with them by the providers. Again, providers prioritize sharing informations on the side effects, more on the side effects than the real importance of the commodities with the clients. So their focus is much on the side effects instead of focusing on the importance of the family planning method. So because of the limited number of staffs in these facilities that we visited, usually clients stay for longer hours to receive these services. Again, there's an absence of cohesive work plan in these states that we've visited, judging from the interviews we've conducted with the county health department, the state minister of health, as well as some of the implementing partners in the locations we visited. Next slide. I also wanted to share with you some insights from the process that we conducted in relation to the tools that we used. We realized that using of the journey map tools and the scenarios in the client's interview guides help a lot in visualizing the work-related opportunities and challenges. And this enables us to unpack the situations that affect the providers. Also, the tools that were used, I think, very good because most of them reflected the context. For example, the tools that we use in the country here, the provider behavior change tool we use, most of them reflect the context of South Sudan. For example, when we talk about the client's interview guide tools, I think most of the questionnaires are very good and they're so interactive, which enables us to get some of the informations we wanted to get from the clients. The tools also provide a more just and balanced forum for collaboration among multiple family planning stakeholders. For example, the clients that we interviewed, as well as the implementing partners and the county health or the state ministry of health officials, they were able to confess that this tool created, I think, a sense of thinking in their mind of the activities they're trying to implement, which I think is a very good kind of starting point for this provider behavior change tool in the country. Also, the processes of this provider behavior change tool helps amplify the voices of the clients, which were not included during planning sessions. So it's an important tool that we really need to adapt in South Sudan. Also, one of the insights that I wanted to share with you is that while engaging the implementing partners in this and the communities, we realized that the implementing partners and also the government have no serious coordination in terms of information sharing. Next slide. From the testing that we conducted, we were able to collect some voices, and these voices are from the locations that we've conducted this provider behavior change tool testing. And one of the voices or one of the feedback we received was from the State Minister of Health official in Yambio, who said these tools are very good. They help them in igniting thinking. It helps them in igniting and the thinking around activities, coordination challenges, and opportunities for providing better service in their state. In WOW, one of the implementing partners also said, okay, it helps them in creating an understanding and the monitoring of planned activities, which of course, yes, from the tools that we tested, we realized that the tools are very good and it enables people to be able to gauge how far you've gone with the activities, or what are the challenges, what needs to be done. Yeah, so those are some of the things. And the last one was from Young Biomedical Director. He said it's an awakening tool. It's a tool that awakens people who are sleeping to realize what is going around with the activities or with in their vicinities in relation to the activities that they're implementing in the counties. Next slide. Thank you, everyone. I think that is the end of my presentation. I'm happy to receive your questions. Thank you.
Thank you very much, Kenny, for your presentation. And before we move on to the question and answer session, we'll again take a moment to share reflections about the Pbc Toolkit by reflecting on these two questions. Please, next slide. Oh, okay, sorry. Yeah, this slide. Thank you. So how do you see yourself applying these tools to your work? And what do you need to apply these tools to your work? Please, again, share your reflections in the chat box. Thank you. Thank you, everyone, for sharing reflections. Please keep those reflections coming and put them in the chat box. We'll quickly move on to the question and answer session, and we'll be taking the questions which had been posed in the chat box during the presentation. And I'll be directing the questions to our various speakers. Okay, so I'll be starting with questions which were posed about the provider behavior ecosystem map. And I'll direct the first question to Danette. And the question goes, concerning the provider behavior ecosystem map, how were the interactions pinpointed and validated? Were these identified by providers themselves or through evidence reviews? Is there any sense of the degree to which these components do or do not impact provider behavior? Over to you, Danette.
Hi, Kemi. Thank you so much for sharing that question from the chat, and happy to respond to it. So just to share with everyone, the provider behavior ecosystem was developed through a user-centered design process that began with a landscape review on provider behavior change. It was then followed by an expert learning forum that included 60 people from 11 countries in this process. And there are also 2 co-design workshops that were held in order to prototype the development of this ecosystem map and iterate and revise it as necessary. And following these 2 co-design workshops, there was further user testing and additional iterative process in order to finalize it. So this map is based on evidence review, and it's also based on inputs from individuals around the world who are heavily involved in provider behavior change programs and initiatives. And additionally, I can share that this co-design workshop really allowed us to validate and prioritize the core relationships across the ecosystem, identify key components involved in these core relationships across the system, and really understand some of the end user needs around visualizing and using an ecosystem map and what the important features would be in order to facilitate that understanding and use of such a tool. I hope that answered the question, but if there's anything else that I missed, I'm happy to share more.
Thank you, Danette, for answering that question. And I'll be posing the next question to Alice. And the question goes, we would love to hear more about the process of agreeing on the key challenge per country. Over to you, Alice.
Thanks, Kemi. So as I mentioned, we use the ecosystem to present basically what we had heard in each of the countries. And then we worked with Ministry of Health representative, partners, and providers themselves to really prioritize in each countries what did they see as the 3 top challenges, like the most pressing issues, which we included in what we call déclaration d'intention. So it's like a formalized paper for each country to outline which challenges they thought were the most kind of pressing. And then obviously we ask ourselves the question, what role should WABA be playing, and where are we best placed to work, basically. And so it was like that lens on what are the most pressing challenges, and then where is WABA best place that really help us identify in each country one top challenge. And that decision was made ultimately by the Ministry of Health, but obviously informed by all of the parties that were in the room at the time. I hope that clarified the question.
Okay. Thank you very much, Alice. And back to you, Danette. The question says, the PBC ecosystem map was creatively done. Are there any other ways to make this simpler, considering the implementation perspective? Over to you, Danette.
Thanks, Kemi. So again, I want to emphasize that the provider behavior ecosystem map is a thinking tool. So it's really an opportunity for you to just visualize and appreciate the wide universe of factors that can influence provider behavior, so that you can consider them as you continue to deepen your understanding of provider behavior in your particular environment. So you really will want to conduct assessments, secondary research, and use some of the additional tools that Heather Hancock shared with us earlier, the diagnostic, the synthesis, and other tools, to be able to translate what you are learning and gathering from the provider behavior ecosystem map into actual practical application to your work. Thanks so much, Kemi, and over to you.
Okay, thank you. And back to you, Alice. The question goes, curious why you did not do any observations of clinical consultations, the gold standard of behavior change formative research. Over to you, Alice.
Yeah. So that's a very good point. So the main reason for not doing that at this stage was very much in relationship to kind of research limitations. So in terms of IRB and in terms of what was feasible with like the length of the project and the budget that was made available. So obviously, you know, it would have been great to be able to observe, but as we know, that can also have kind of a significant impact on the quality of the counseling. And so that's why the research was really designed with interaction with provider themselves and supervisor of providers. The solutions, however, that are being designed are not going to be tested in real life settings with feedback from women themselves in the form of client exit interviews to ensure that we have that we have feedback from clients, women and young women themselves. But yes, very good point. But yeah, difficult with kind of budget and time available, basically.
Okay, thank you. And back to you, Danette. The question goes, can the process of using the provider behavior ecosystem map likened to HCD with providers, that's human-centered design with providers?
Thanks, Kemi. And apologies if I'm misunderstanding the question. I do want to reiterate that the development process for the provider behavior change, or excuse me, provider behavior ecosystem map was through a user design process. Now, on the other end of things, and actually applying this tool to your work, I think it could actually be an exciting opportunity to directly engage providers in considering all these different factors that might influence how they're able to do their work and interact with clients in different settings.
Kemi, if I could just add one thing to that as well. During that design process, we did also conduct interviews with providers to better understand the factors in several different countries. And so while they were not as directly involved in that co-design process that Danette was just mentioning, they were involved in helping us to ground truth some of the things that we were hearing through that the evidence review and the co-design process with other stakeholders as well.
Okay, thank you, Heather, for that additional information. And back to Alice, the question goes, what was the starting point, e.g. low intake of services, direct feedback from clients? What was the starting point that prompted the process?
So that's an excellent question. So I think it was a mix of different things. One was this research was very much triggered by some of the work that was done in terms of engaging with community. So we had activity called community dialogue for communities to be able to voice some of their concern and the challenges they were facing. And as part of this exercise, provider behavior actually came up as, one key challenge. And it was also, I think, also a broad remit of WABA, who was interested in intervention that were looking at the, not just the supply, but very much that question around provider behavior change. And we were very well aware that there were already interventions that had been designed, but not for the West Africa context. So that was, yes, both surfaced by the communities themselves, plus an interest from a kind of research and design perspective from Breakthrough Action to really understand and find solutions that could be specific to these countries. And then finally, obviously, some strong support from the Ministry of Health in each of the countries. Thank you.
Okay. Thank you very much, Alice. And we'll be moving to questions that were about the Pbc toolkit. So the first question goes to Heather, and the question is, how does this model address factors that are out of control of healthcare workers?
Thanks, Kemi. Really, the whole purpose, I would say, of the toolkit is to help us find factors that might be influencing provider behavior from multiple levels or perspectives. And some of those definitely will be outside of the provider's control. And so that part of the reason for doing that is to look at that district level, look at the community level. Certainly social norms play a role. Certainly the ministry's role plays, it definitely influences provider factors. And so we want to be able to see not just what's directly in the provider's control, but what's also external to their control. And through that process of getting input from those multiple levels and seeing those different factors from observations and discussions, there is that opportunity to then figure out what all is influencing provider behavior, not just those internal factors to providers that they directly have control over. And then through that process, design solutions that can address all of those factors that are prioritized, not just the ones that providers can directly manage.
Thank you, Heather. And over to Kenny. Can you elaborate a bit on step 1, defining the behaviors of interest? Over to you, Kenny.
I didn't get your question. Come again, please. Thank you.
Okay, so the question says, can you elaborate a bit on step 1, which was defining the behaviors of interest?
Okay, the question may be, is it related to the tools that we used? I don't get it.
Yes.
Heather, may you,
so in the process of testing and adapting the PBC toolkit, you mentioned that you carried out a step of defining behaviors of interest. So the question is, can you elaborate a bit on that?
Okay, on the behaviors of interest, we were looking at what are some of these behaviors that enables providers to be able to conduct their activities diligently, or what are some of these behaviors that makes them not to be able to do their activities diligently. And when we interviewed providers, we were able to find out that some of them are related to the social norms and others are related to the religious norms, where you find a person who is affiliated to one religion moves or carries those behaviors to a facility, which now makes it difficult, or it makes the clients not to be able to come for these services, because it makes them like, okay, ask questions that are related to their religion. That makes client feel like, okay, if this person is asking such a question, then it makes no sense me coming for these services in the facility. Yeah, so basically it is the social norms and then the religious norms which are mainly affecting the providers' behaviors.
Okay, thank you.
I don't know if I answered his question well.
Yes, thank you very much, Kenny. There's also opportunity if any other panelists would want to give some more insight. Heather, do you have any more?
Yeah, thanks, Kemi. I think, so from my perspective, as we were designing the toolkit, one of the things that we discussed is what would launch the use of this toolkit, what would prompt that. And one of those things could be that there are some data coming through the HMIS or otherwise that show us that there may be some challenges in a particular facility, or they're not necessarily meeting certain standards that we want them to meet. And so that could potentially prompt that question of what's going on in this facility, so that we can explore that a little bit more deeply. And so that would also provide an opportunity to start saying, what are the behaviors of interest and what exactly do we want to be exploring here? And so part of that process is not necessarily included in the toolkit per se. There's not a set of tools that address that component of defining those behaviors, but it would be something that would be a starting point before you start going into that diagnostic process to say, what is the behavior that we're looking at? What is the actual challenge? So that's one part of it, is that process of perhaps seeing data would prompt that decision-making process around what behaviors should be the behaviors of interest. The toolkit could also potentially be used just more as we want to improve or support positive behaviors among providers. And so going into that with eyes wide open and trying to understand what exactly is affecting their behaviors on a number of levels. And so it could be something that you also look at a little bit more broadly, rather than having one or two specific behaviors in mind when you start that process. And so they're meant to be a little bit open in that sense, but there aren't specific tools that help you identify those behaviors. And perhaps that's something that could be added as we continue to iterate on these tools.
Okay. Thank you, Heather. The next question, I'm directing it again to you, Heather. And it says, is there any reason you did not include monitoring and evaluation as part of the 3 tools?
Yeah, thank you for that question. And as part of the action planning process, we do have an opportunity to define indicators and how you want to track those indicators. That said, there's not a specific set of tools that, identify how you will evaluate that, but there is that included in the process of identifying how you're going to implement this and how you will monitor and measure your success based on those indicators. I would say that, again, that could be an opportunity to integrate some of those. Breakthrough Action is also working separately but relatedly on a journal article right now with breakthrough research that identifies some potential theories and and other tools for measurement of provider behavior change that could be integrated into these tools as well.
Thank you, Heather. And the last question goes to Kenny. Were there any gender-related barriers that came out through testing these tools, during your testing of these tools?
Yes, there are gender-related barriers that came out of the testing of the tools. I think from our findings in these 3 locations that we conducted the provider behavior change, we realized that men tend to make decisions on behalf of their women. And also, whenever they find women using family planning services secretly, they tend to create some gender-based violence on the women who are taking these family planning services. Thank you.
Okay, thank you so much. Thank you all presenters for answering these questions. We have come to the end of the Q&A session, and I hope the audience has gained some more insight into these tools through the answers which were provided by the speakers. So at this point, I'm going to be sharing some more information about the upcoming Pbc workshop. Yes, so like Heather had mentioned during her presentation, we're going to have a Pbc workshop, which will hold in May and June. And during this workshop, we're going to support participants to learn more about these tools we have shared and apply them in their work. So this is a very exciting opportunity, and it's a free technical assistance opportunity. So these are the key dates. The applications open today and will be closing February 28th. And then there will be a selection process, and applicants will be informed about their success or not by April 8th. And this is a team-based event. Applicants will be applying as teams of 3 to 5 persons, which we feel will make it easier for them to be able to actually apply these tools to their work. So we'll be sharing the link. Okay, thank you, Kendra. Kendra has shared the link to the application form. So please consider applying and also share with your network widely. And with this, we come to the end of our webinar. Thank you so much for staying this long. And before you go, please take a moment to provide feedback by answering these poll questions. Thank you so much.